Hello, my name is Dr. Roger Henderson, and I'm a GP, and I also co-host the GP Notebook study groups. Welcome to this GP Notebook podcast, where we discuss bite-sized topics aimed at all those working in primary care. Now you can find us on all major podcast platforms, including Spotify, Apple Podcasts, and Google Podcasts. So do please follow us to receive notifications about new episodes, and if you like what you hear, do please consider leaving a review to help other listeners find us. You can also follow us on Twitter at GPnotebook for more information about new podcast episodes and study groups, and you can find me on there too at Roger the Doctor. Finally, you can visit GPnotebook.com for podcast episode show notes and to find out more about upcoming study group meetings, which occur throughout the year. Now, in this episode, I'm going to do a brief overview of hypothyroidism, which, as we all know, is increasingly common in our ageing population, and is essentially a clinical state resulting from underproduction of the thyroid hormones thyroxine, T4, and triiodothyronine, 2,3. Now, most cases that we see in primary care are due to failure of the thyroid gland to produce sufficient thyroid hormones in response to TSH, the thyroid-stimulating hormone. And this is primary hypothyroidism. And as the TSH levels increase to try to correct the low thyroid hormone levels, this results in abnormally high TSH levels in combination with low T3 and T4 levels. And I'll go through these in a little bit more detail later. Secondary hypothyroidism, on the other hand, is caused by underproduction of TSH by the pituitary gland. And subclinical hypothyroidism can also occur, and we covered this in a previous podcast, so do go back and look that one up. Now, this is usually asymptomatic and has only a minimally increased level of TSH and normal levels of T4 and T3. So just to remind us about the main thyroid function tests used to diagnose hypothyroidism, the TSH and the free T4. So primary hypothyroidism has TSH levels above normal and free T4 below normal, and that's overt hypothyroidism. Subclinical hypothyroidism has an FT4 within the normal range, and the TSH levels are slightly raised. Secondary hypothyroidism, on the other hand, has TSH levels below normal as well as a free T4 below normal. I'll just remind us those later on again in the podcast. Now, the prevalence of treated hypothyroidism in the UK is projected to be around 3 million by 2025, and it is undoubtedly more common in women by men, and some estimates have this as being a factor of 10 to 1. Other risk factors include a family history of hypothyroidism, being obese, being white, and going through the menopause. Subclinical hypothyroidism is actually more common, being found in up to 10% of the population, and this also increases with increasing age. Now, globally, although not in the UK, the most common cause of hypothyroidism is iodine deficiency in the diet. But in this country, in an iodine-rich country such as ours, the usual causes are increasing age and conditions such as autoimmune thyroiditis. Less commonly, primary hypothyroidism can be caused by damage to the thyroid gland itself from treatments such as radioactive iodine, for example, or radiotherapy for head and neck cancer. And we also mustn't forget that there is some iatrogenic causes of hypothyroidism with drugs such as lithium, which interferes with thyroid hormone production and release, and amiodarone, which contains iodine itself and so interferes with thyroid hormone production. Now, as we all know, there are multiple conditions which can mimic hypothyroidism, as well as many non-thyroidal conditions that can lead to abnormal thyroid function tests. And examples of these I'm thinking about are things like Addison's disease, celiac disease, type 1 diabetes, and rheumatoid arthritis. Now, in older people, symptoms of dementia can be extremely similar to those of hypothyroidism, and that can be tricky, as can post-viral syndromes, and we have to include long COVID here now, obviously, chronic fatigue, and fibromyalgia. Unfortunately, in some menopausal women, their symptoms may be assumed to be due to menopausal factors rather than to thyroid dysfunction. And we also mustn't forget the relatively common condition obstructive sleep apnea, as that may often not be considered as a cause unless the symptoms are specifically asked about. Now, when we're taking a history from a patient with suspected hypothyroidism, we're obviously going to ask about any typical symptoms, all linked to the general slowing down of metabolism that we know well. And so obviously these include things like fatigue, constipation, weight gain, aches and pains, and feeling cold, even in warm weather. And I distinctly remember diagnosing a patient with undiagnosed hypothyroidism in the summer months one year when he came in wearing 3 jumpers while the rest of us were in short sleeves. We also mustn't forget things like a dry skin and coarse hair, mental slowing or cognitive slowing such as brain fog, a hoarse voice, irregular or heavy menstrual periods and fertility problems, poor libido, and also carpal tunnel syndrome. It causes pain, tingling, and numbness in the hands. And I have seen patients presenting with carpal tunnel syndrome who actually have hypothyroidism. Now, in many of these patients, because their symptoms typically develop extremely slowly and then gradually worsen over months or even years as their thyroxine levels gradually fall, some patients, especially older ones, will dismiss these symptoms simply as part of getting older without realizing they have any problem with their thyroid gland at all. So after you've asked about the typical symptoms, ask the patient about any medications they're taking and look for risk factors such as a family history of thyroid disease, for example, and any history of autoimmune disorders such as type 1 diabetes, Addison's, celiac, pernicious anemia, or vitiligo. And also don't forget to ask whether there's been any previous surgery or radiotherapy treatment to the neck or thyroid area. When we then come to examine the patient, always check for the presence of a goiter, thyroid nodules as well, and if there's any obvious general or localized thyroid swelling, then ultrasound imaging should be sought. And in addition, look for signs of autoimmune disorders such as vitiligo, as well as physical signs including slow speech and movement, coarse dry skin, bradycardia, hypertension, eyelid edema, and delayed tendon reflexes. Now, although most people with hypothyroidism don't have any associated eye problems, hypothyroidism itself can occasionally cause swelling around the eyes, some eye discomfort, very occasionally visual disturbance, and a slightly nuanced sign of a lack of outer eyebrow hair. That's a nice one to look for. But obviously, do remember too that patients may have no symptoms at all or slightly vague, non-specific symptoms such as fatigue or low-level cognitive impairment that may be overlooked or dismissed. So, when we're going to test, obviously obtain a TSH and a full blood count in any patient I would suggest who presents with non-specific fatigue and weight gain or the signs and the symptoms we've just discussed. And also remember that patients with hypothyroidism can be at a higher risk of anemia compared to patients with normal thyroid function tests. Now, we all know that the TSH test is the most sensitive and specific primary care blood test that we do when diagnosing primary hypothyroidism. And if the TSH is below the reference range, then measure the free T4 and the free T3 in the same sample. So check the thyroid function tests, check for anemia, and I would also suggest we should check the patient's lipid status too, as both the total cholesterol and low-density lipoprotein levels may be elevated in hypothyroidism. So, just looking at the thyroid conditions with those blood tests once more. If we've got thyroid hormone resistance, then the TSH is raised or normal, and the T4 and the T3 are both raised. That's thyroid hormone resistance. In primary hypothyroidism, the TSH is raised, but the T4 is lowered and the T3 is lowered, although that may be normal. In secondary hypothyroidism, the TSH is lowered or normal, the T4 is lowered, and the T3 is lowered or normal. It's also probably just worth mentioning that anti-thyroid peroxidase antibodies, anti-TPO, or anti-thyroglobulin antibodies are found in about 90 to 95% of patients with autoimmune thyroiditis. Now, NICE recommend measuring the thyroid peroxidase antibodies for adults with TSH levels above the reference range. And further tests that may be considered include calcium, liver function tests, HbA1c, and LFTs. So what about referring our patients if we're not going to start treatment ourselves? Well, they should certainly be referred if they're aged under 16 with hypothyroidism, if they're pregnant or postpartum, or if there's any evidence of pituitary disease. And I would also suggest that referral should be considered if symptoms don't respond or even worsen after treatment with levothyroxine, if there's active and unstable ischemic heart disease, if the patient's taking amiodarone or lithium, or if the serum TSH level is persistently raised whilst on full doses of levothyroxine. But if it's felt that specialist referral isn't needed, always treat primary hypothyroidism with levothyroxine monotherapy. And obviously the general aim of this is to achieve normal levels of circulating thyroxine targeted to the clinical response and thyroid function test results, along with regular treatment monitoring in the form of blood tests to avoid both under and over treatment. In mild subclinical hypothyroidism, a wait-and-see strategy is absolutely fine to see if results settle back to normal, but anyone with cardiovascular disease and subclinical hypothyroidism may benefit from levothyroxine treatment. Now, if you're starting levothyroxine, advise the patient to take it on an empty stomach in the morning before other food or medication, and don't forget to say to our patients they're entitled to free prescriptions if they're not already receiving this. Now, the current clinical guidelines from NICE, which I have to say do differ very slightly from BNF guidance, but which many physicians choose to follow, recommend starting thyroxine at a dosage of 1.6 micrograms per kilogram body weight per day for adults under 65 years of age with primary hypothyroidism and no history of cardiovascular disease, and 25 to 50 micrograms per day if there's a history of cardiovascular disease. The BNF recommends a dosage regime for adults aged 18 to 49 of initially 50 to 100 micrograms once a day, adjusted in steps of 25 to 50 micrograms every 3 to 4 weeks, and adjusted according to response, to a maintenance dose usually of 100 to 200 micrograms once daily. If cardiovascular disease is present in adults aged 50 years and over, the dose should initially be 25 micrograms once daily and adjusted in steps of 25 micrograms every 4 to 6 weeks according to the response, to a maintenance dose of 50 to 200 micrograms once daily. Now, always remember to tell the patients that symptoms may not improve immediately, and say it may take several weeks or even slightly longer after starting treatment or altering a dosage for improvement to occur, or they may not improve if they've got another cause, such as tiredness due to life stress, for example. And I'd also note that in clinical practice, even if the TFTs settle within the normal range on treatment, for some people, changes in their thyroxine dosage may further improve their symptoms, and this is where it becomes a little bit of an art rather than the science. But there's a caveat here. There is a risk that patients can increase their dosages to an unnecessarily high level, and they must be advised against this because of the possibility of triggering symptoms of hyperthyroidism linked to that. Now, some patients with hypothyroidism who don't feel particularly unwell, or whose condition we pick up unexpectedly as part of blood test screening for other conditions, such as diabetes, for example, may ask us why treatment is important. And I think we should remind them that hypothyroidism can have significant complications if left untreated, including impaired quality of life, metabolic syndrome, dyslipidemia, coronary heart disease, stroke, and even heart failure. There's also an increased risk of fertility problems longer term and cognitive impairment. The good news that we can tell our patients that their prognosis is typically good and that the condition is readily treatable with thyroxine, although daily lifelong treatment with thyroid hormone will obviously be required. They should also be told that regular blood tests are going to be needed to determine if their dose of thyroid hormone is sufficient for them. And these are initially every 4 to 12 weeks until stabilised. And then, when they're on the correct dose, I normally do these once a year. But it is important that the patient gets these tests, and they also know that spontaneous remission without treatment is rare. I think it's also worth mentioning that up to 10% of our patients may remain symptomatic, such as having cognitive impairment or impaired well-being, up to 6 months after treatment has started, even when their thyroid function tests have returned to normal. And it's helpful for them to know that. Compared to undiagnosed or undertreated hypothyroidism, studies have shown that treating hypothyroid patients to maintain TSH hormone concentrations within normal limits long term has no difference in the pattern of long-term health outcomes. And I think that's encouraging. So I do hope you found that podcast helpful. So do have a look at the show notes that accompany this episode at GPnotebook.com, and we'd be very grateful if you consider following the podcast and leaving us a review on your favourite podcast platform. Do feel free to get in touch via social media at GPnotebook or email us support@GPnotebook.com if you have any questions, comments or ideas for future podcasts. You should also visit us at GPnotebook.com to register for our many virtual GP Notebook study groups we have going all year round, and to download free shortcuts to help improve the lives of our patients in primary care. But as always, until the next time, goodbye.